class will be on enteric fever. So in the next few minutes, introduction, problems, epidemiology, pathophysiology, clinical features, diagnosis, treatment, control, and finally vaccine for the typhoid fever. So this is the international classification disease codes for the typhoid fever. It is 002 ICD-9 and ICD-10 it is A01. So this is derived from the ancient Greek typhus, almost resembles like the typhus at that time. They thought that it is all because of the smoke or the cloud that was believed to cause the disease or the madness. And you know that this is the Salmonella species, so Salmonella Typhi or Paratyphi, etc. Adapted for growth in both humans and the animals, cause a wide spectrum of the disease. Growth of the serotypes, Typhi and Paratyphi, is restricted to the human host and cause enteric fever. So as far as the Typhi and Paratyphi are concerned, there is exclusively for the humans, whereas the other bacteria of the Salmonella can infect both the humans as well as the animals. And not only this fever, it causes a wide spectrum of the disease. It's a systemic disease, typhoid. So almost all the systems in the body will be affected with the typhoid fever unless you diagnose at a later time. So a word about the non-typhoidal Salmonella, call it as NTS. Non-typhoidal Salmonella remaining the serotypes can colonize the gastrointestinal tracts of the broad spectrum of the broad range of the animals, including the mammals, reptiles, birds, and insects. More than 200 serotypes are pathogenic to the humans. So they cause gastroenteritis, localized infections, bacteremia. Okay. So these are some part of the non-typhoidal Salmonellas. So what is typhoid? It's a result of the systemic infection. So it's a systemic disease, not a localized disease caused to the gastrointestinal system. So beyond the gastrointestinal system. Clinically characterized by the typical continuous fever. Book says that is a stepladder pattern. But usually nowadays we are not seeing the stepladder pattern because of the early initiation of the antibiotics by the family members or by the RMPs or by the pharmacy population, etc. So nowadays, no, the fever is not a stepladder pattern, but classically it is of the stepladder pattern. The fever lasts for about 3 to 4 weeks, and there will be the relative bradycardia. So for every 1 degree rise of a foreign heat, so there will be a rise of the pulse by 10 beats per minute. But here in the typhoid fever, there will be the relative bradycardia. So in spite of the 2 degrees or the 3 degrees of the rise in the foreign heat, so you may find the rise in the pulse rate maybe 5 beats or the 10 beats or the 15 beats, not the 30 or the 40 beats as usual. And there will be the involvement of the intestinal lymphoid tissues, the Peyer's patches, small intestines, reticuloendothelial system, your spleen will be involved here, gallbladder, liver, bone marrow, and gallbladder. And gallbladder is the one which carries a lot of the bacilli in that. So almost the chronic carriers will be there. So they keep on shedding the bacilli in the stools to cause many infections in the humans. Example is your typhoid Mary. So the enteric fever includes both the typhoid and the paratyphoid fevers, may occur sporadically, epidemically, and endemically. So in India, it's almost like a 365 degrees, 365 days disease. So the typhoid fever. Okay, they find only in the humans because the Salmonella Typhi and the Paratyphi, they exclusively for the humans. So there are the famous historical personalities related to the typhoid. Antonius Musa is a Roman physician who achieved the fame by treating the emperor 2000 years ago. How he treated? Not with your ciprofloxacin or your erythromycin, just with cold baths. When he fell ill with the typhoid, so cold bathing. At that time, in 2000 years ago, that was the only treatment given by the Roman physician, and he was appreciated a lot by emperor. Later, the Thomas Willis, who is credited with the first description of the typhoid fever in 1659, he described the typhoid fever first. Your stepladder pattern or your continuous fever or the fever with the gastrointestinal symptoms, etc. And he is a French physician, Pierre Charles Alexandre Louis, first proposed the name typhoid fever. And William Wood Gerhard, who was the first to differentiate clearly between the typhus and the typhoid in 1837. So earlier, no, they thought that it is also very close to the typhus. And they given this word as a typhoid fever, like your rheumatic and rheumatoid. But later you all know that the typhus is totally different from our typhoid fevers. So it's the Carl Joseph Ebert who discovered the typhoid bacillus in 1880. So a credit goes to the Ebert for his beautiful description of the typhoid bacillus. And finally, the Vidal, George Vidal, who described the Vidal agglutination reaction of the blood in 1896, still going strong. Vidal, especially our rural India, even in Rajahmundry or in Kakinada also, a lot of the people, they say that Vidal positive, I am suffering with the typhoid. So what to do? This is the third attack of the fever in the last 2 years or the 3 years with Vidal positivity. So credit goes to the Vidal who first described the Vidal agglutination reaction of the blood in 1896. Now a few words of the epidemiology. So as I told you that it is no more a localized disease, it is a systemic disease characterized by the fever and the abdominal pain. That is the reason we call this considered as the enteric fever. Enteric means your gastrointestinal. Okay. So these people will have the abdominal pain. Not all people will have the abdominal pain. Maybe 30 to 40% of the typhoid fevers, they have the abdominal pain caused by the dissemination of the typhi or the paratyphi in the Peyer's patches, etc. Initially called typhoid fever because of its clinical similarity to the typhus. In the early 1800s, typhoid fever was clearly defined pathological as a unique illness on the basis of its association with the enlarged Peyer's patches and the mesenteric lymph nodes. In 1869, given the anatomic site of the infection, the term enteric fever was proposed because of its anatomical site, because the infection is in the Peyer's patches or the small intestines. Then the two designations are used interchangeably right now, both enteric fever and the typhoid fevers. The etiological agents for the enteric fever, your typhi and the paratyphi, serotypes A, B, C, have no known hosts other than the humans. Humans are only hosts there. Yeah. Most commonly, it is a foodborne or the waterborne transmission, results from the fecal contamination by ill or asymptomatic chronic carriers. So, the very common route is our foodborne or the waterborne. So, hand hygiene is very important and protected water supply is very important to control the typhoid fevers. Sexual transmission is also there between the male partners and healthcare workers. They are all exposed to these organisms and they are vulnerable people to have the typhoid fever because of their acquaintance with the exposure to the infected patients or during the processing of the clinical specimens and the cultures in the microbiology department. So she is Mary Mellon, 69 to 38, also known as the Typhoid Mary. She is known to have infected more than 5,000, not 53, maybe more than the 5,000 population, whom 3 of whom died from the disease. Her notoriously denial of her own role in spreading the disease, refusal to cease working as a cook. She was a cook, but refused to stop working there. Forcibly quarantined twice by the public authorities and died in the quarantine period. Possible that she was born with the disease, as her mother had the typhoid fever during her pregnancy. So this is the Typhoid Mary. Okay. So she was a cook and responsible for the transmission of the disease in few thousands population, and some of the people also died because of this disease. So she was quarantined for twice. Mary Mellon, also called as Typhoid Mary, in a hospital bed. First one, she was forcibly quarantined as a carrier of the typhoid fever in 1907 for 3 years. So 3 years quarantined in the hospital. And again, from 15 until her death in 38. So that means nearly how many years? Yeah. Okay. So that's how that is the story of the Typhoid Mary, who has given a lot of the carriers. She is a big carrier of this disease. With improvements in the food handling and water and the sewage treatment, enteric fever has become rare in the developed nations, but not in Indian population because of the very bad food handling and no protected water. So sewage systems are also not good. Drainage systems are not good in India. So these are still very, very important reasons to cause the enteric fever in our population. There were estimated 22 million cases of enteric fever. You see, remember that numbers, but the very high number of the population all over the world are suffering with the enteric fever. See, I think in Western population, it is about 0.2 cases per 1 lakh population. Whereas in India, it is 800 to 1000 cases per 1 lakh population. So see, 0.2 versus 800 to 1000 cases. So that is the difference between the West and Indian population as far as the incidence of the enteric fever is concerned. See, the incidence of the strongly endemic is our India and subcontinent. India, Pakistan, Afghanistan, so all these places, and also Africa. Not in Europe or in Australia or in North America. See, high intensity of the enteric fever correlates with the poor sanitation and lack of access to the clean drinking water. That clearly shows that India is still a developing one only. In endemic regions, it is more common in the urban than the rural areas and among the young children and the adolescents. Why it is more common in the urban? Because of the population aggregation. So in the bus stands, in the railway stations, or in the airports, in the melas, okay, in the malls. So a lot of the people gather there. So this is a reason for the enteric fever more in the urban and also in the no more rural. There is always urbanization of the rural areas there. So that means I strongly feel that now it is common in both urban and the rural areas. What are the risk factors? So as I told you that contaminated water or ice creams, flooding, food and the drinks purchased from the street vendors, raw fruits and vegetables grown in the fields fertilized with the sewage. So without cleaning the fruits or the washing the fruits very properly. Ill household contacts, lack of hand washing and the toilet access. Evidence of the prior Helicobacter pylori infection, an association probably related to the chronically reduced gastric acidity. So it's more common in the chlorhydria population. So those people who are taking the antacids, those people who are taking the PPAs, that's very common in our practice. So to prescribe the antacids and the PPAs. So chlorhydria is another indication to cause more and more enteric fever causes, because the bacilli once the bacilli is there in the stomach, when the fellow is having the chlorhydria, so it will easily goes to the duodenum and the ileum. So easily it traverses from the stomach to the small intestines in the presence of the chlorhydria. So naturally it reaches the small intestines or distal ileum and then attacks the mucosa and then the submucosa and then finally to the lymphoid tissues or lymphatic spread to your lymph nodes or to the spleen or the liver or the gallbladder and the bone marrow. And again there will be a second bacteriemic spread or second hematogenic spread is also there to cause the brain, heart, lungs, etc. So that's how they develop the sepsis. So there will be the two hematogenic spreads. So first one from the Peyer's patches to the lymphatic tissues, and the second one from the spleen or from the liver or from the bone marrow to the distal areas like the brain, etc., or the spine. It is estimated there is one case of the paratyphoid fever for every 4 cases of the typhoid fever, but I don't agree here. But lot of the peer, I think 90% of cases we see are the typhoid fevers rather than the paratyphoid fevers. But in India, the incidence of the infection as with the paratyphi appears to be increasing right now. Now the multi-drug resistant or extended drug resistant typhoid is also very common. So earlier, no, typhoid fever means very good response to your chloramphenicol or your amoxicillin or your ampicillin or your cotrimoxazole, that is the trimethoprim and sulfamethoxazole combination. Excellent response, 99.9% responses. Later, very good response to your fluorocranilins like your ciprofloxacin or ofloxacin. Now that is also resistant. Earlier, then later, we got very good response to the azithromycin. Now that is also becoming the resistant. Now the only drug which is not that much resistant is the meropenem. Okay, so it is not possible for all the cases. So what are all the drugs I know? I told you right now. So ranging from the chloramphenicol, ampicillin, amoxicillin, cotrimoxazole, azithromycin, your ceftriaxone or cefixime, and then the meropenem. So these are all the drugs are very useful drugs in typhoid. So multi-drug resistant. So that is emerged in the 1889 in China and also in Asia, have since disseminated widely all over the world. These strains contain the plasmids encoding the resistance to the chloramphenicol, ampicillin, and trimethoprim sulfamethoxazole combination. That is the cotrimoxazole. Antibiotics long used to treat the enteric fever. These three antibiotics were used extensively in those days. Okay, so they are the chloramphenicol, ampicillin or amoxicillin, and cotrimoxazole. So for all these three, there is the resistance. That resistance we call it as MDR resistance, multi-drug resistance. With the increased use of the fluoroquinolines, ciprofloxacin and the ofloxacin to treat the MDR enteric fever, strains of the typhi, paratyphi, with reduced susceptibility to ciprofloxacin emerged in India and also the Vietnam. Now that is also becoming very resistant. I think in India, ciprofloxacin and ofloxacin resistance to the typhoid fever to the tune of about 60 to 70% right now. So a very good number of the people are resistant to the ciprofloxacin or the ofloxacin to the typhoid fever with the treatment failure. It is prevalent in many regions in the world. High intensity, high endemicity, or very high risk in Indian population. So the lot of the people are there. Highly adapted, human-specific pathogen occurring more frequently in underdeveloped regions of the world, where overcrowding and poor sanitation are prevalent, like our country. So this is the very high number infected every year. So this is also very good. So kills, good mortality is there. Even today, 5 to 10% of the very severe enteric fever population, they are going to die because of the sepsis, because of the encephalopathy. So because of the neutropenia, because of the bone marrow suppression, because of the acute kidney injury. So these are all very diseases, a dreadful disease, left untreated in very severe fevers. See, the 62% of these occurring in Asia. So 60 to 70% of these cases are in Asia, and among the Asia, India will be the #1 country here. So now India, world largest outbreak of the India typhoid occurs in Shangli in December 75 to February 76. This disease is endemic in India. See the deaths and the cases, 92, 93, 94, 11, nearly the millions, lakhs and lakhs of the cases, even 346 deaths. The prevalence 88 cases per 1 lakh population. Case fatality 1 to 2%. Even today 1 to 2% is the mortality rate of enteric fever, typhoid fever. See in Southeast Asia, 50% more of the strains or bacteria has the MDR. I think that even more than the 50%, maybe 70 to 80% are now resistant to all the three drugs. That is MDR drug resistance means resistance to chloramphenicol, ampicillin, amoxicillin, cotrimoxazole. See, only 4% of the travelers diagnosed with enteric fever gave a history of vaccination within the previous 5 years. Still, the vaccination for the typhoid fever is underreported. So, those people who want to travel to the endemic areas, those fellow coming from the west to the India, so they has to be given enteric fever vaccination. So, only the 4% of the travelers are getting the vaccination. Increased rates of the MDR typhi and paratyphi have been reported among the travelers. So, those travelers are getting the drug-resistant enteric fever. 80% of the US travelers with enteric fever acquired in Vietnam are infected with multi-drug resistant strains. So what are the determinants in epidemiology? What are some of the agent factors, host factors, environmental and social factors? What about the incubation period and mode of the transmission? So host. Typhoid fever mainly caused by the bacterium Salmonella Typhi from the family Enterobacteriaceae. Para A, B and also C. They are relatively infrequent, but nowadays paratyphi A is increasing in its incidence. It's a gram-negative bacilli, facultative aerobic, non-spore forming bacteria that is motile due to the flagella. So this typhi will have the flagella, that is the motile. It is a gram-negative one. It grows best at 37 degrees centigrade. Here are the two sets of the antigens, O antigen and H antigen. O is also called as the somatic and H is called as the flagellar antigens. So somatic are the O antigens. They contain the long chain polysaccharides. LPS comprises the heat stable polysaccharide commonly. So the LPS will be seen in O antigens, that is somatic antigens. What of the H antigens, flagellar? They are strongly immunogenic and induces the antibody formation rapidly and in high titers following the infection or the immunization. So you will find the high titers in the H antigens. So Salmonella O may be 1 in 60 or 1 in 80 or 1 in 120 or 1 in 160, but H may be 1 in 320. So very high titers will be seen with the flagellar antigens following an infection or the immunization. The flagellar antigen is of dual nature occurring in one of the two phases. So this is the one. Color pink there for the gram negative. Here this is the flagella. So the flagellas are clearly seen here. It is the gram negative one. The size is only 0.5 microns, 1 to 3 by 0.5 microns. Resistance of the Salmonella. Live 2 to 3 weeks in the water. 1 to 2 months in the stool. Boiling, chlorination, pasteurization destroy the bacilli. So these two things you should remember. So they live in the water 2 to 3 weeks. In the soil, even the months also, 1 to 2 months also. So that is in rural India. So it's more because of the Salmonella in the water and in the stool. Boiling, chlorination, pasteurization destroy the bacilli. So this is the pathogenesis. So ingestion, then it attaches to the microvilli, it goes to the ileum, distal ileum. So more in case of achlorhydria. When the feces is having more and more acidity, so it will not enter into the small intestine. And then it penetrates to the lamina propria and the submucosa. There it is phagocytosis by the polymorphs and the macrophages. Then they reach the lymph nodes. That is the mesenteric lymph nodes. There they multiply. Then they invade the bloodstream via the thoracic duct. And then it enters into the liver, gallbladder, spleen, kidney, and bone marrow. After multiplication, these bacilli passes again into the bloodstream. There is a second blood spread. Then to the different parts in the body, maybe the brain or heart or the lungs or etc. or the spine or bones. So there is a difference between case and the carrier. A case is infectious as long as the bacilli appear in the stools or the urine. It may be the mixed case because the patient is asymptomatic, or the mild with just fever and mild abdominal pain, or severe with all the symptoms. So these are the cases. Carrier, there may be the temporary incubatory excretory bacilli for about 6 to 8 weeks, or the chronic carrier. So these are the more dangerous ones. They excrete the bacilli for more than a year. Organism persists in the gallbladder or the biliary tract. So clear-cut example is your Mary Mellon. The same one here. See, she was a cook in New York. Give rise to more than 1300 cases in her lifetime. 1300 cases. She died of pneumonia after 26 years in the quarantine. So she was quarantined for twice. So she died in the hospital with pneumonia. So this is the source of the infection, the primary sources and the secondary sources. So the primary sources is the feces and the urine of the cases and the carriers. So both the case in the acute phase or the carrier, maybe the temporary carrier, the chronic carriers. So they shed the bacilli in the feces and the urine. So that's how it's a primary source. And fecal carriers are more frequent than the urinary carriers. And secondary sources, contaminated water, food, fingers, flies. So this already I told you, typhi, same ingestion of the contaminated food or water, small intestine and enter the bloodstream. Then the liver, spleen and the bone marrow, there the multiply and again re-enter into the bloodstream and then to the gallbladder, biliary system, lymphatic tissue, bowel, multiply in the high numbers. Then they pass into the intestinal tract and can be identified by diagnosis in the cultures from the stool tested in the laboratory. So age at any age, but usually the children are more prone to have the typhoid fevers between the 5 to 20 years of the age group. More common in the males than the females. Nowadays, I think, don't think, earlier no, males means they move in the, females usually they stay in the house. But now the females are also seen in the markets. So no more sex differentiation. Both the males and females are equal. Carrier rate is more in the females. Immunity. Antibody may be stimulated by the infection or the immunization. Antibody against the O antigen is higher in the patient with the disease, and antibody against H antigen, that is the flagellar antigen, is higher in the immunized person. Typhi is intracellular organism or cell-mediated immunity plays a major role in combating the infections. So these are all the environmental and social factors. It is regarded as the index of the general sanitation in any country. So the more the enteric fever means, so what about your general sanitation is good or bad? Bad. Okay, no typhoid fevers means general sanitation is very, very good. So it's almost an index of general sanitation as far as the typhoid fever or your gastroenteritis is concerned. Increase in incidence in the July to the September. Outside the human body, bacilli found in the water 2 to 7 days but not multiply. Soil irrigated with the sewage about 1 to 2 months. Ice and ice cream over a month. Food multiply and survive for some time. Milk grow rapidly without altering its state. Vegetables grow in the sewage plant. Pollution of the drinking water supplies. Open area defecation and urination. Low personal hygiene and health ignorance. So these are the very, very important environmental social factors. So all these factors are very, very there in our Indian population, both in urban and rural India. So this is the mode of the transmission, the fecal-oral route or urine-oral route, but mostly 99.9% is the fecal-oral route, either directly through the hands soiled with the feces or the urine of the cases or the carriers, or indirectly by the ingestion of the contaminated water, milk, food, or through flies. Contaminated ice or ice creams and milk products are a rich source of the infection. Incubation period usually 10 to 14 days, but it may last for maybe range maybe 3 to 21 days, depending upon the dose of the bacilli ingested. Very small dose is required, is sufficient to cause the typhoid fever. Maybe 10 to the 4 or 3, I think, bacilli are sufficient to cause typhoid fevers. So coming to the clinical features, the first week, second week, third week, these are the very, very important in the typhoid fevers. The first week, you will have the fever, some headache, malaise, maybe cough, mostly the dry cough, sore throat. So these are all in the prodromal stage. The disease classically presents the stepladder fashion. That means first day it is about 99 degrees. In the second day it is 100 degrees. Third day 101. Fourth day maybe 1045. That is the stepladder pattern. In the same way, the decrease in the temperature is also follows the same pattern. So it won't touch us to the normal immediately in the typhoid fever. But usually nowadays we are not seeing this because of the early usage of your paracetamol, Dolo 650 or your antibiotics. Accompanied by the headache, vague abdominal pain, constipation or the pea soup diarrhea. Both are common in typhoid fever. Not always 100% diarrhea. Sometimes no, constipation is also common in typhoid fevers. So the second week, between the 7th to 10th day of the illness, mild hepatosplenomegaly because the reticulous blood, okay, occur in the majority of the patients. Maybe the 2 fingers enlargement of your liver, or maybe 1 to 2 fingers enlargement of your spleen. Relative bradycardia, this already I told you, may occur, and there sometimes road spots may be seen, but not exclusively seen in our dark-skinned population. But some people you can see the rose spots in the anterior chest and the posterior chest. Third week is a very dangerous one. Typhoid state, in which a state of prolonged apathy, toxic, delirium, disorientation, and sometimes comatose also. Diarrhea will then become the apparent. If left untreated by this time, there is a high risk, 5 to 10% of the intestinal hemorrhage and the perforation. So these two are very, very common in the third week of the fevers. So third week, mostly the surgical fever. First and second week, physician fever. So we should not allow our patients to enter into the surgical arena. So we have to stop the fever by second week. So you have to diagnose the enteric fever much early and then act accordingly. So always think of your MDR and XDR resistance. So then use the appropriate antibiotics to kill the bacilli as early as possible. Otherwise, in the third week, a lot of the people will go into the hemorrhage or the perforation. So this perforation is small intestinal perforation, not the large intestinal perforation. Maybe the ileal perforation. And rare complications, hepatitis, pneumonia, thrombophlebitis, myocarditis, cholecystitis, nephritis, osteomyelitis, and sometimes psychosis, psychotic behavior. Okay. So 2 to 5 patients may become the gallbladder carriers. So chronic carriers. So this is about our clinical features in the first week, second week, third week, and finally rare complications, almost all organs in the body. So your brain will be involved, heart will be involved, lungs will be involved, spine will be involved, bones will be involved, and finally your mind also will be involved in psychosis. So same thing here, the clinical syndromes are indistinguishable. Both the typhoid and paratyphoid, they almost behave like a same in the first week, with your fever, with your headache, with myalgia, etc. Begin 7 to 14 days after ingestion of the organism, because incubation period is 10 to 14 days, or as short as the 3 days, or as long as 21 days. The fever pattern is stepwise, means it gets higher over the day and then drops by the morning again. Over the course of the first week of the illness, the gastrointestinal manifestation of the disease develop. These include diffuse abdominal pain and tenderness, sometimes colicky, right upper quadrant pain. Maybe the cholecystitis, gallbladder is involved there in the second week. So that could be the reason for your hepatitis and the cholecystitis. So right upper quadrant pain. Monocytic infiltration inflames the Peyer's patches and narrows the bowel lumen, causing the constipation. So the constipation causes here. Okay. Narrows the bowel lumen because of the inflamed Peyer patches. So the patient develops the cough, it is the dry cough, dull frontal headache, delirium, and an increasingly stoporosed rose spots. They are truncal, maculopapular rash, usually 1 to 4 centimeters weight. These generally resolve within the 2 to 5 days. Approximately at the end of the first week of the illness, the fever rises at about 103 to 104 degrees Fahrenheit. Second week, the abdomen becomes distended. Okay, and soft splenomegaly is common. First is hepatomegaly, and the second week you will have a splenomegaly. And relative bradycardia and dicrotic pulse. That is the double beat. The second week weaker than the first may develop. Third week more toxic, anorexic, weight loss. The conjunctiva get infected, becomes tachypneic, thready pulse, and crackles over the lung bases. Abdominal distance is very severe. Patients experience foul, green, yellow, liquid diarrhea, that is a pea soup diarrhea. Individual may descend into the typhoid state, characterized by apathy, confusion, and even psychosis. Necrotic Peyer's patches may cause bowel perforation, peritonitis. It may be mistaken by the corticosteroids. So overwhelming toxemia, myocarditis, intestinal hemorrhage may cause death also. So that is the cause of the death in typhoid fevers. Maybe 5 to 10% of the population in the third week or the fourth week, they die because of the myocarditis or the hemorrhages. If the individual survives to the 4th week, usually that occurs nowadays because of the good understanding of the pathophysiology of the typhoid fever, we don't allow the patient to die in the 3rd week. Then what about in the 4th week? The fever, mental state, abdominal distension slowly improve over a few days. Intestinal and neurological complications may still occur in surviving the untreated individuals. Weight loss and weakness may last for the months. Some survivors become asymptomatic carriers and have the potential to transmit the disease indefinitely. So this is the diagnostic description of the symptoms: high fever, headache, asthenia, weakness, dry cough, abdominal pain, not stomach pain, abdominal pain, okay, constipation or diarrhea, and rashes, your rose spots or papular rash. So this is the typhoid fever, fevers, these spots, symptoms. See, enteric fever is a misnomer. Hallmark features of the disease, fever and abdominal pain, are variable. Not in all cases you will have this fever and abdominal pain. Fever is present in about 75% of the cases, and abdominal pain is only in 30 to 40% of the cases. So even in the absence of the abdominal pain also, you should suspect enteric fever. So high index of suspicion for this potentially fatal systemic illness is necessary when a person presents with a fever and history of the recent travel to a developing country. So the travel history is also very important. This already told you the incubation period 10 to 14 days, or may range from 3 to 21. Depends on the inoculum size and the host health and immune state, obviously. So when the fellows have immune system is good, immunity is very good, so definitely you won't get the enteric fever. The most prominent symptom is a prolonged fever. Continue for up to 4 weeks if left untreated. And the typhoid A is thought to cause milder disease than the typhoid, with a predominantly gastrointestinal symptoms. See here the percentage of the symptoms in some cases. Headache in about 80% of the cases. Chills and rigors, a classical example for your malaria or the sepsis, etc. 35 to 45%. Cough, dry cough in 30%. Sweating, 20 to 25% of the cases. Myalgias, 20%. Malaise, 10%. Arthralgia, 2 to 4%. Whereas in dengue, more of arthralgia, more of myalgia, more of retroorbital pain, more of the fever there. So the fever, retroorbital pain, myalgia, arthralgia, more in case of the dengue fever, even without the rash also. Okay, here in typhoid fever, you will have the fever, headache is more, dry cough, and abdominal symptoms. Maybe the constipation or the diarrhea, mostly abdominal pain and diarrhea rather than the constipation in our places. So these are the gastrointestinal symptoms like anorexia, abdominal pain, nausea, vomitings, diarrhea, constipation. Physical findings, coated tongue. So this is a very important in typhoid fever. Okay, so you have to see the tongue. Tongue is coated in about 51 to 56% of the cases. Splenomegaly in just 5 to 6%, and abdominal tenderness in 4 to 5%. So among the signs, the coated tongue is a very, very important sign in the enteric fevers. So the rash here, the rose spots, hepatosplenomegaly, epistaxis. So in some cases, relative bradycardia, already told you at the peak of the high fever. So these rose spots are the faint, salmon colored, blanching, maculopapular rash, located primarily on the trunk and the chest. Rash is evident in 30% of the patients at the end of the first week and resolves without a trace after the 2 to 5 days. So mostly it appears at the end of the first week and maybe the mid-second week they resolve. The patients can have 2 or 3 crops of the lesions. Salmonella can be cultured from the punch biopsies of these lesions. Even the skin biopsy, that rose spots biopsy, can also be done, but here we don't do it. Development of the very severe disease occurs in about 10 to 15% of the patients. It depends on the host factors like your immunosuppression, antacid therapy, previous exposure and the vaccination. Strain virulence. When the strain is very much virulent, so definitely most of the people will have the infections, and choice of the antibiotic therapy. So the wrong antibiotic, the antibiotic is resistant, so the fever will persist. So gastrointestinal bleeding and the perforation, so 10 to 20% or 1 to 3%. From hyperplasia, ulceration, necrosis of ileocecal Pierce patches. See here, Janardhan, Chepra X-ray Chepra. How to read the chest X-ray PA view? Anyone? Final year postgraduate, how to read a chest X-ray PA view? Bharat, you are the right person. How to read the chest X-ray PA view? No. I am not asking about the findings here. So how to read a chest X-ray PA view? What are all the points you are supposed to read? Basics. So what are the points you are supposed to see? Trachea, clavicles, diaphragms, right border of the heart, left border of the heart, hilum, okay, upper lobes, mid lobes, lower lobes of the lungs, okay, and subcutaneous tissues. Okay, so you have to comment on all these things. Okay, what about the trachea? Is it in the midline or deviated to the one side or pushed to the other side? Okay, then what about the clavicles? They are the central are placed equally, or any fractures or any secondaries? What about the right heart border? Right heart border. What about the left heart border? Is there any cardiomegaly? So obviously here, no cardiomegaly here. Okay. What about the upper lobes, lungs? Here any tuberculous lesions here, fibrotic zones or cavities, and in malignant lesions, Pancoast tumor. In the mid lobes, any pneumonitis or any bronchitis. Okay. In the lower lobes, what are the costophrenic angles? Any pleural effusion? Any lower lobe abscess formations? Lung abscesses? Or lower lobe pneumonia? Consolidation? Or pneumonitis patches? Or chronic bronchitis? Okay, no. So these are all things you are supposed to see in these areas. Okay. And what about the vasculature? Pulmonary artery. What is the aorta? Any calcification of the root of the aorta? Any Kerley B lines? What of the diaphragm? Right side and the left side. Gastric shadow on the left side. See here the right side. Below the diaphragm, you are having gas shadow. So that shows perforation. Okay, Janardhan, Adhavendra, see the right border, right diaphragm. So gas under the right dome of the diaphragm. It is because of the perforation of the hollow viscous. So the perforation of the small intestine. So this is a complication of the typhoid fever in the 3rd week or in the 4th week. So immediately you have to subject them for surgical consultation and the correction. So am I clear? So the both complications of the life-threatening, both the hemorrhage as well as the perforation, they require immediate fluid resuscitation and the surgical intervention. Broad and antibiotic coverage for the polymicrobial peritonitis. So both the gram-positive, gram-negative anaerobic organisms. So maybe the 3rd generation cephalosporins or the amikacin or metronidazole. So they're all needed for your peritonitis. Treatment of the gastrointestinal hemorrhages and bowel resection is also possible here. Neurological manifestations in 2 to 40% of the patients. The severe typhoid fevers. They include meningitis. So typhoid meningitis, Guillain-Barré syndrome, typhoid neuritis, neuropsychiatric symptoms suggesting as muttering delirium or coma vigil, with picking at blood clots or the imaginary subjects, objects. So this is the neurotyphoid. So the typhoid concerning with your brain and the mind. So the meningitis, Guillain-Barré syndrome, neuritis, and neuropsychiatric symptoms. So this is the common in severe typhoid. So these are all the rare complications whose incidences are reduced by the prompt antibiotic treatment. So we don't allow our patients to reach these stages. But in spite of that, when you are in the emergency department, sometimes you are supposed to see these cases. So because of the fever of the 15 days duration, fever of 20 days duration, fever of 1 month duration, there you have to think of the 3rd week or the 4th week complications of the typhoid, like what are all the complications I told you. Along those complications, these are also there. Dick, pancreatitis, abscesses in the liver and the spleen, hepatic and the splenic abscesses, granulomas, endocarditis, pericarditis, myocarditis. So you need ultrasound abdomen to detect these abscesses and also 2D echo to know the vegetations or pericarditis or pericardial effusions or vegetations, endocarditis. So in those patients with the fever of 3 weeks duration or 4 weeks duration on the bedside, we are supposed to get the ultrasound abdomen and also 2D echo to rule out these complications. Arthritis, hepatitis, glomerulonephritis, pyelonephritis, hemolytic uremic syndrome, severe pneumonias, arthritis, osteomyelitis, parotitis. Up to 10% of the patients, they develop the mild relapse within 2 to 3 weeks of the fever resolution. Say sometimes we often see the same fellow coming again with the recurrence of the fever. So this is the up to 10% of the patients of typhoid fever, they develop the mild relapse. Same strain type or susceptibility profile. So the same thing, the first week and the end of the first week. See the end of the first week, we will have the rose spots, splenomegaly, okay, dry cough, abdominal distension, and the diarrhea. Carrier, up to 10% of the untreated patients with the typhoid fever excrete the typhi in the feces for up to 3 months. They are the carriers. 1 to 4% develop the chronic asymptomatic carriers, shedding the Salmonella Typhi in either urine or the stool for more than 1 year. Chronic carriers is more common among the women and the infants. Persons with biliary abnormalities or concurrent bladder infections with the cystosoma hematobium. The anatomic abnormalities associated with the latter conditions presumably allow the prolonged colonization. So these are the chronic carrier state. So about 10% of the untreated patients they develop, but usually there will be about 1 to 2% of the typhoids will be the carriers. So the chronic carriers mostly the women and the infants. It is a bile, gallbladder is at fault. So sometimes we have to subject for the cholecystectomy also. So for these chronic carriers who are shedding the bacilli, so you have to subject for the cholecystectomy. So one of the indication for the cholecystectomy is chronic carrier state of the typhoids. See here, typhoid abscess, otitis media, severe mental confusion, bed sores, deafness, Jenker's degeneration of the muscles, boils for the axilla, tonsillitis, dehydration. See, you are agree with me that typhoid fever is not just fever and abdominal pain or the diarrhea. So it's a big systemic disease. It's truly a physician's disease, typhoid fever, especially in the 2nd week and the 3rd week. So you only people can detect all these complications and treat the patient properly. Otherwise, they are going to die or they are going to be the chronic carriers. Chronic carriers. Okay. See the typhoid abscess, otitis media, mental confusion, bed sores, deafness, tonsillitis, dehydration. See the meningitis, severe bronchitis, hemolytic anemia, venous thrombosis, myocarditis, pneumonias, nephritis, peripheral neuritis. So these are also important in typhoid fevers. Almost all organs in the body will be involved in the chronic typhoid fever. So these are surgical complications: parotitis, typhoid spine, paralytic ileus, pyelonephritis and cystitis, intestinal hemorrhage, typhoid arthritis and typhoid osteomyelitis, architis, intestinal perforation, cholecystitis, empyema. So these are all the surgical complications. So see how many medical and the surgical complications of the typhoid fever are there. So these are very, very common. Okay. Now these are the specimens. See the terminal ileum, how bad it is. Okay. See the John Hunter's specimens, terminal ileum, enlarged Peyer's patches, thinned out areas ready to the perforate. Okay. So because of these Peyer's patches, infiltrations, etc., so they become very, very thin and finally prone for perforation. So this is the intestinal bleeding, sudden drop in the blood pressure and shock, followed by the appearance of the blood in the stools. So abdominal distension, tachypnea, tachycardia, hypotension in a fellow with a fever of 3 weeks duration or the 4 weeks duration. So what is your diagnosis in the bedside? It is maybe because of the intestinal hemorrhage, because of the uncontrolled or untreated typhoid fevers. So immediately have to subject for the surgical correction. So again the perforation. See the patient with intestinal perforation, showing rapid deterioration of the general condition, early stage of the perforation. So Rayleigh tube aspirations, etc. And then immediately after the vitals are the normal, you have to subject for the surgical. So this is a typhoid arthritis. So typhoid arthritis. So septic arthritis is a very common, polyarthritis. See here osteomyelitis. And sometimes even the fractures. Typhoid osteomyelitis, the second one of the lower femur with associated fracture. This fracture is because of the chronic osteomyelitis, not because of the injury. Like your osteoporosis. See what will happen after the osteoporosis. So the bones will break down. There will be the fractures, osteoporotic fractures. So like this here, because of the typhoid osteomyelitis, prone for the fractures. See the typhoid spine. X-ray thoracic and the lumbar spine showing the complete collapse of the two vertebrae and the intervertebral disc with the partially calcified abscesses. So you can appreciate here on the arrow. So there is the wedge compression of the vertebra. So what about the diagnosis? So you know what are all the clinical features and the medical complications, surgical complications. So now moving to the diagnosis. So the clinical presentation is relatively non-specific. Diagnosis needs to be considered in any febrile traveler returning from the developing country like India, especially the Indian subcontinent. Other diagnoses that should be considered in these travelers include malaria, hepatitis, bacterial enteritis or gastroenteritis, dengue, rickettsial infections, leptospiro, amoebic liver abscess, or acute HIV infections. So these are the common DD for your typhoid fevers. So in the first week and the second week, so these are the very, very common DDs for your typhoid fevers. What are the common DDs? Malaria, hepatitis, gastroenteritis, dengue, rickettsial infections, leptospira, amoebic liver abscess, and acute HIV infections. So positive culture only the specific diagnostic test is not the vital. The most specific diagnostic test is the blood cultures, or the bone marrow cultures, or the urine cultures, or the bile cultures. So the culture and sensitivity is the most standard diagnostic test to detect the typhoid fevers. 15 to 25% of the cases, the leukopenia and the neutropenia are the detectable. Okay, leukopenia and the neutropenia. The same in the last week I discussed about the dengue fever. There also there will be neutropenia and then the thrombocytopenia. Neutropenia appears first and then the thrombocytopenia. So here again in the enteric fever, in about 15 to 25% of the cases, you can see the leukopenia and the neutropenia because it's a gram-negative sepsis. So in the gram-negative sepsis, most of leukopenia. Leukocytosis is also common among the children during the first 10 days of the illness, intestinal perforation, and secondary infections. Other non-specific laboratory findings, moderate to elevated liver function tests, liver SGPT, SGOT will be 110, 120, 150, 200, and muscle enzyme levels. Definitive diagnosis of the enteric fever requires isolation of the typhi or paratyphi from blood, that the blood culture and sensitivity, bone marrow, other sterile sites, rose spots, stool, and intestinal secretions. Yield of blood cultures is quite variable. The sensitivity is as high as 90% during the first week. So in the first week, 90% positivity for your blood cultures. Whereas the second week, maybe 60%. In the third week, maybe 20 to 40% only. So in the first week, the high yield is there with about 90% sensitivity with the blood cultures. Decreases to 50% by the third week. Low yield in infected patients related to the low numbers of the salmonella, less than the 15 microorganisms per ml. Recent antibiotic treatment. So that is the reason our blood cultures are mostly the negative, because by the time they reaches to you, they have used 2 or 3 antibiotics. Okay, so the partially treated patients with an antibiotics, so the yield of your blood cultures is very much low. Centrifugation of the blood and cultures of the Buffy coat substantially reduce the time to isolation of the organism. Does not increase the sensitivity. Typhi organisms in the blood are associated with the mononuclear cell or the platelet fraction. Unlike the blood culture, bone marrow culture remains very highly sensitive despite the 5 days of the antibiotic therapy. So in spite of the 5 days of the antibiotic therapy, if you get the bone marrow biopsy, that will be the positive. But that is not possible because it's an invasive procedure. Culture of the intestinal secretions, the best obtained by a non-invasive duodenal stenting test, can be positive despite a negative bone marrow culture. So when the fellow is having some surgical complication, when you are putting the Ryle's tube, so then you can send the Ryle's tube aspiration material for your blood and for your culture and sensitivity. If blood, bone marrow, intestinal secretions are all cultured, the yield is about 90%. If you send all the 3, then more than the 90% you can positive, whether it's the blood or the intestinal secretions or the bone marrow. Stool cultures negative in about 60 to 70% of the cases during the first week. Become positive during the third week of the infection in untreated patients. So stool cultures in the first week, 60 to 70%, they may be the more positive in the third week. Vidal test for the febrile agglutinins. None of these tests is sufficiently sensitive or specific to replace the culture. So still the culture is the gold standard. High rates of false positivity and false negativity. These tests are not clinically useful. Vidal test. Lot of the false positives and the false negatives. Even today, I am not able to read the Vidal in the context of the patients. So the patient is totally febrile, but here Vidal shows 1 in 320 or 1 in 3. On the other hand, the fellow is having the fever with abdominal pain or pea soup stools or the rose spots or parotitis or architis, etc. But here the Vidal test is 0, nil, negative, or maybe 1 in 40 or 1 in 160. So it's very false positives and the false negatives are very common with the Vidal tests. PCR is very good, and DNA probe assays to detect the typhoid in the blood are being developed now. Okay. So the disadvantages of the traditional tube Vidal tests are time taken to demonstrate a rise in the titer, delay or absence of the antibody response in the some patients, high titers of the antibody present in the certain populations, difficulties of interpretation of the results in those previously infected, vaccinated, or started in the antibiotic treatment, or cross reactions between the salmonella and the related organisms. So even though the patient is not suffering with the salmonella, maybe other related organisms, they also cause viral positivity, even though the patient is totally asymptomatic. And sometimes viral positivity are always positive this month, next month, and after 2 or 3 months also, even though the patient is afebrile and away from the infections. See here, the blood cultures are positive in the first week, 90%, second week, 75%, the third week, 60%, and the fourth week and later, so 25%. So if you want to send the blood cultures when you are suspecting the entry fever, so the best time is in the first week itself. So this is your McConkey's agar, Wilson and Blair bismuth sulfate medium jet black colony with a metallic shell. So these are all the bacteria there. Significant titers help in the diagnosis of your viral. Serum eglons rise abruptly during the second or the third week. Following the titers of the antibodies against the antigens are significant when the single sample is tested. O more than 1 in 160, H more than 1 in 320. So O is somatic and H is flagellar. Okay. So the limitation of the viral test already I told you. So again, I would like to repeat here. Classically, a fourfold rise of the antibody in the paired sera test is considered diagnostic of the typhoid fever. Fourfold increase. However, paired sera are often difficult to obtain and specific chemotherapy has to be instituted on the basis of a single viral test. In areas where the fever due to infectious causes is common occurrence, the possibility exists that false positive reactions may occur as a result of non-typhoid fevers. So nowadays, typhoid dot test. Okay, strip tests. So they are also available. So they detect the presence of IgM and IgG in 1 hour. Here the sensitivity is 95%, specificity is of 75%. Typhoid.m that detects the IgM only. Here the specificity is 93%. Okay. Typhoid.rapid. Here the specificity is 99%. Is a rapid 15-minute immunochromatographic test to detect the IgM. So all these are available right now. So along with the viral test, if you are in a doubt whether it's a false positive or the false negative, you can subject them for this typhoid dot, yeah, or typhoid dot rapid, where the specificity is nearly 90%. So the diagnosis is useful in the public health purpose because we want to control the other population, other fellows, not to have the occurrence of the typhoid fevers. So useful in the screening the food handlers, cooks to detect the carrier state. Can be isolated from the feces and from the bile aspirants. Detection of the V1 agglutinates in the blood can be determinant of the carrier state. So in the vaccine, here you can see the V1, typhoid vaccine, V1. So to detect the things, the vaccine costing about 1500 rupees, 1500 rupees to 2000 rupees, may be given once in 3 years or once in 5 years. Booster dose has to be given for this vaccination. So these are all the misdiagnoses already. DDs already told you all these things. See the paratyphoid fever similar to the typhoid but usually less severe. Paraenteric fever, a typhoid-like fever but not caused by the salmonella. Gastroenteritis, a mild case of the typhoid may be mistaken for the gastroenteritis. Malaria, typhomalarial fever because of fever, chills and rigors, some spots, etc. Brucellosis, early tuberculosis, infective endocarditis, Q fever, rickettsial, acute diarrhea, viral hepatitis, lymphomas, adult Still's disease, malaria, and then acute HIV infections. So these are all the misdiagnoses or DDs for your typhoid fever. So how to control of the typhoid fevers? Control of the reservoirs, cases and the carriers, control of the sanitation and immunization. So I think the second one is more important. The first one is important as far as the person is concerned to relieve of the fever. And the second one is very important to control the transmission of the disease. And of course, immunization is also very important. So early diagnosis by culture of the blood and the stool. Notification done where it is the mandatory. Isolation till the 3 negative tests. Treatment by the appropriate antibiotics. Disinfection of the stool and the urine by 5% cresol for 2 hours and close by 2% chlorine. Follow-up examination of the stool and the urine at 3 to 4 months and at 12 months after the discharge. So general measures, supportive care, adequate hydration, antibiotics, nutrition. This is also very important. So the nutrition is very important in all the infectious fevers. Specific, you know that antibiotic therapy is the mainstay. So all these antibiotics already told you. In case of the quinolin resistance, you can go for the azithromycin or the third generation cephalosporins. And even today, azithromycin is resistant, even the ceftriaxone is also resistant. Then you can go for the meropenem, carbapenem, imipenem or meropenem. So these are the chain of the drugs which are useful in enteric fever. See the fully sensitive antibiotics, chloroquine or ciprofloxacin or the varfloxacin, 15 milligrams per kg body weight, 5 to 7 days. Multi-drug resistant, fluoroquinolone or the cefixime. Where the quinolin resistance, you can use the azithromycin or the ceftriaxone. So same thing here. Uncomplicated drug resistance. So you can use the ciprofloxacin or ofloxacin. Or complicated drug resistance, you can go for the intravenous ceftriaxone or the intravenous ofloxacin. In the MDR, peroral you can go for the cefixime or the azithromycin. In complicated, you can use the ceftriaxone, that is your monosef, aztreonone or the imipenem or the carbapenem. Same thing here. A treatment, a prompt administration of the appropriate antibiotic therapy prevents the severe complications of the enteric fever and results in a case fatality rate of less than 1%. See, for treatment of drug susceptible typhoid fever, not the drug resistant, drug susceptible, the fluoroquinolones are the most effective drugs. Cure rates 98%. Relapse on the fecal carriage is less than the 2%. Experience is most extensive with the ciprofloxacin. Short course ofloxacin therapy is similarly successful against the infection caused by the nalidixic acid susceptible strains. Increased incidence of nalidixic acid resistant Salmonella Typhi and AC is also there, probably related to the widespread availability of the fluoroquinolones over the counter is now limiting the use of this drug class for the empirical therapy. So most of the people, even the RMPs and at the medical shops, they give the Cefran or Quentar, ciprofloxacin for most of the fevers. Okay, so that is the reason that it has become the resistant in majority of typhoid fevers. So patients infected with the nalidixic acid resistant Salmonella Typhi should be treated with ceftriaxone, azithromycin, high dose ciprofloxacin, 750 milligrams BD, or high dose fluoroquinolone therapy associated with the delayed resolution of the fever and high rates of the fecal carriers during the convalescence. So same thing here. Patients with the persistent vomitings, diarrhea, under abdominal distension. So don't give OP based management. So the fever with extensive gastrointestinal symptoms. So always hospitalize and give the supportive therapy, mostly the intravenous therapy, parenteral therapy. So the parenteral third generation cephalosporins like your ceftriaxone or fluoroquinolone, maybe IV ciprofloxacin or IV ofloxacin, depending on the susceptibility. Therapy should be administered at least 10 days or 5 days after the fever resolution. This is the most practical point. So most of the typhoid fevers know once the fever is afebrile, when the person is afebrile on the 5th day or the 6th day, don't stop giving the antibiotics. Give for 5 more days, even after the subsidence of the fever. So you have to give 5 days after the fever resolution in all the complicated typhoid fevers. What about the steroids? Usually you say no, but typhoid encephalopathy, so you can use the steroids. See the prospective double-blind study, a critically ill patient with enteric fever, those with shock and obtundation in Indonesia in the early 80s, administration of dexamethasone with chloramphenicol. Also, there is a substantially lower mortality rate than the treatment with the chloramphenicol alone. The study has not been repeated in the post-chloramphenicol era. Severe enteric fever remains one of the few indications for the glucocorticoid treatment of an acute bacterial infection. So these are all the important antibiotics. Already I told you. Medical care, antibiotic resistance, surgical, diet. Fluids and electrolytes should be monitored and replaced diligently. Very, very important diet. So as long as the patient is not having any nausea and the vomiting, so can allow the oral nutrition therapy. Otherwise, your parenteral nutrition therapy is also important. So oral nutrition with a soft digestible diet is preferable in the absence of the abdominal distension or the ileus. Carriers identify by culture and serological examination. Treatment by intensive course of the ampicillin or amoxicillin with the probenecid for 6 weeks. So at least 1.5 months, or the 2 months, or the 3 months, you have to give the treatment for this carrier typhoid virus, like your chronic complicated UTI. Surgery like cholecystectomy, if needed. Kept under surveillance, and health education is very important here. Hygiene is very important. Control of the sanitation. So purification of the drinking water, basic sanitation improvements, food hygiene, simple hand hygiene and washing can reduce several cases of the typhoid. So this is a very important public point. Immunization, you have the vaccinations recommended to those living in the endemic areas like all of us, household contacts, groups at risk like school children and the hospital staff, those attending the melas and the yatras. There are 3 types of the vaccines. Injectable typhoid vaccine, Typhon V1 is now available. I told you the cost is also 1,500 rupees to 2,000 rupees. Live oral vaccine and the TAB vaccine. So here this is efficacy about 64% to 72%. It is IM injection. Typhoid is a live attenuated bacterial vaccine. Prevention already I told you. Vaccines. So this is the vaccination at a school, because the school going children are more prone for this. So large scale meta-analysis. Immunity lasts for 3 years. So they need a booster dose once in 3 years or once in 5 years. Okay. Vaccines are not effective in the prevention of the paratyphoid fevers. These vaccines only for the typhoid fevers. So the typhoid fever prevention already told you, the hand hygiene. Okay. Wash hands, drink boiled water, clean fruits and the vegetables, and get vaccinated once in 3 years or the 5 years. So here is one index case. A 42-year-old female presents to you with complaints of high-grade fever, 1 or 2 degrees, for the past 3 days, not responding well to the self-administered paracetamol, abdominal distension, dyspepsia, headache and myalgias, weakness, several episodes of passing semi-solid stools. So what is your diagnosis? So female, high fever, 3 days, not good response to the paracetamol, also having abdominal distension, dyspepsia, headache, myalgia, asthenia, and passing semi-solid stools. So probably in the first week of typhoid fever. Okay, in the first week of typhoid fever, so this typhoid already attached to the Peyer's patches. So intestinal symptoms here. So intestinal symptoms and vague symptoms. Reported to have visited her native during the vacation 2 weeks back. Okay, she went to Bhimavaram 2 weeks ago. Physical examination reveals rose spots on abdomen. No known history of other metabolic conditions. Key diagnostic findings: mild elevated liver enzymes. DOT ELISA test detects the IgM antibodies positive. So your diagnosis is typhoid here. So infections impacting the nutritional status. So the malnutrition and infections, so go hand in hand. So inadequate dietary intake. So obviously immunity loss, and then low immunity, so the more severe infections. So this malnutrition and infections is a big chain. And nutritional management is also important. Proteins are the building blocks of the body. They are required for the building the muscle mass. Sources: milk, eggs, sprouts, fish and chicken. Vitamins and minerals, they are a catalyst for the healthy growth. Improves the eyesight, make bones and teeth strong. Sources: fruits, green leafy vegetables. Carbohydrates and fats are required to provide the energy. Fats help the absorption of vitamin A, D, E, K. Fats provide the protective cushion of our organs. And sources: rice, sugar, corn, bread, cereals, butter, oil, chicken. So the proteins are needed, vitamins are needed, and carbohydrates and the fats are also needed. So what is your advice here for your patient? Oral rehydration therapy with further assessment. We have given the cefixime and paracetamol. Anything missed? We have given a good antibiotic and also paracetamol. So oral nutritionist supplementations, delivering the complete and balanced nutrition. So you have to talk about the nutrition part also in all the fevers along with your antibiotics and the paracetamol. So please talk on the nutrition part also. Okay. So the patient may be eating good at home, but this may not be adequate. So what about your vitamins, minerals, proteins? These are all very important. Okay. Here only carbohydrate and some snacks. So the finally, gradual onset of malaise, headache, nausea, vomiting, abdominal pain, rose spots, relative bradycardia, splenomegaly, abdominal distension and tenderness, step ladder rise of the fever to the maximum and then slow return to the normal, leukopenia, blood and stool and urine cultures positive for Salmonella. So this is the final picture of your typhoid fever. Some symptoms, some signs, okay, then the diagnosis by the cultures. Thank you very much for your patient hearing.